Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Right. We do have Dr. Thomas Salinas in the house today. Professor Thomas J. Salinas is a professor of dentistry at the Mayo Clinic College of Medicine. He received a prosthodontic and undergraduate training at the Louisiana State University Health Science Center, and is maxillofacial and prosthodontic training at the UTMD Anderson Cancer Center in Texas. He's a diplomate of the American Board of Prosthodontics and a fellow of the American College of Prosthodontists, a member of the American Dental Association, amongst other organizations. He has a dual clinical appointment as a consultant in the Department of Dental Specialties, devoting his practice to rehabilitation of patients requiring prosthodontic care. He maintains several editorial review positions with the International Journal of Prosthodontics, the International Journal of Oral and Maxillofacial Implants. He's also on the editorial council of the Journal of Prosthetic Dentistry. His research interest includes biomechanical aspects of dental materials, implant prosthodontics, and clinical outcome studies. Dr. Salinas, it's a pleasure to have you on Dental Webinar Series today.
Thank you, Dr. Onoriobe. Pleasure's mine. I really appreciate the opportunity to share just one aspect of what we do at Mayo Clinic. It's a team approach, and I'll get into that in just a few minutes. I'd like to welcome all of you throughout the world. Good morning, good afternoon, good evening, wherever you are. But we certainly would appreciate the opportunity to dialogue with you at the end of this. So a lot of what's happened in the last 10, 15 years with technology has changed the approach of what we do every day. As a prosthodontist, I see lots of hospital and routine prosthodontic cases. Some of the work that we're doing is certainly not in a silo. We operate with a lot of our colleagues in surgery, and it makes it a real challenge to be able to keep pace. It seems that every couple of years we've got a new platform to work off of. So this can be really very advantageous for the patient, but it keeps us on our toes. So I hope to share some of these issues with you today. A lot of the work I do is, again, with colleagues, Dr. Alan Carr, who some of you probably know with his work in biomechanical studies at The Ohio State University, and our other colleagues, Dr. Olivia Muller and Dr. Sarah Lee, who some of you probably know as well with their work here in the States and elsewhere. So some of you might ask, where's the Mayo Clinic at? I know it's in Minnesota, and I know it's cold up there around this time of year, but it is southeast of the Twin Cities, about 75 miles. It's a beautiful area year-round, a little bit more hospitable in the summertime. North of Minneapolis is where the cradle of the Mississippi River begins. One of the greatest rivers in North America begins at Lake Itasca, north of Minneapolis. And it literally is a trickle throughout this stream as it starts out here. So if you ever come to this part of the country, please take some time and get to see it. It's beautiful. A lot of the Great Lakes and adjoining areas are also quite spectacular, particularly in the summertime when it's hospitable. A lot of the work done at Mayo Clinic had been historic. In George Zarb's introduction of osseointegration into North America, many of you know, it started with approximately 7 institutions. Mayo Clinic is just one of those. But even the local paper here in 1983, Hallmark Branamark with William Laney, our patriarch and founder of our prosthodontic division. So this began many years ago, where Brown and Mark actually operated here and maintained his level of excellence in demonstrating this as a duplicate study in this population as well as in Europe. But a lot's changed since then. We see a number of things that's happened. Technology, of course, I just talked about, but our clinical outcome database is tremendously different now in comparison to where it was. Likewise, patients expect more these days. I mean, we look at the dental IQ our patients have, it's vastly different than it was back then. And the demographic that we're treating is completely different. We have patients that now present with a failing dentition, unlike years ago where it was patients presenting with wearing dentures, complete dentures for years, and they were alveolar, really a shortage of alveolar bones. So this is a tremendously different demographic that we're seeing now in comparison to decades ago. Likewise, if we look at the latest cancer facts and figures, I did a topic on this probably over a decade ago, and I noted that there was 35,000 new cases of head and neck cancer to be identified in this country in comparison to just last year, where this is escalated to approximately 55,000 new cases of head and neck cancer per year. So needless to say, this is drastically different. Much of this, honestly, is, as we are all aware, attributed to human papillomavirus. This typically presents in an innocuous form. The patients are asymptomatic and might actually present otherwise with advanced nodal disease. It typically comes as a younger age group in comparison to years prior. And the way that we're seeing these present is alarmingly increased over the last several years, but even now more so, because oropharyngeal squamous cell is honestly eclipsing all other forms of squamous cell carcinoma. So lots of changes in the last decade. The team that we use to treat and diagnose and treat these patients is variable. And we have diagnostic radiologists, head neck surgeons, oral and maxillofacial surgeons, plastic surgeons. We have radiologic imaging specialists. So there's a tremendous team that we have at the clinic to provide this level of care. I definitely do not do this by myself, and I really have high regard for my surgical colleagues. A lot of the work that's been done in years past is comprehensive treatment. You've seen some of this perhaps in your own area, but a number of our patients are treated with a variety of surgery and usually a combination of adjuvant type of therapy, radiation therapy, chemotherapy if there's systemic involvement. Some of this work has been certainly approached by many organizations, particularly the American Joint Commission of Cancer, and this was put together many years ago. Some of you know this classification system. A lot of it has changed and been modified from system to system, but I think we can say it definitely changes the way in which we approach treating and diagnosing and staging these patients. Some of the work that had been done in years prior began years ago with the development of focal radiotherapy, typically by Fletcher's group at MD Anderson. This had been changed over the years in looking at fractionation, different delivery methods, but linear accelerator definitely had a part in treating these patients, increasing their survival in addition to surgical resection. But in this day and age, we see a lot of things that have changed. Conventional radiotherapy would, even for just head neck tumors and also brain lesions, this would enter and exit, creating both an entry and an exit dose. Charged particle therapy, in addition to other types of therapy now, look at providing a specific level of dosage whereby we do not have an exit dose. And this is done in a sort of a focal pencil beam scanning fashion. This is a delivery method using proton beam technology, and this has increased the amount of effectiveness of radiotherapy, and it's also decreased in many ways, particularly in the area of the head and neck. It's decreased the amount of side effects that we see. Many of the patients that we see this day and age, we know that there are side effects of radiotherapy. Robert Marks classified this as a hypovascular, hypocellular, hypoxic wound. And there are many other side effects of radiotherapy. Although it's effective with the dentition, it could lead to a number of things: endarteritis, premature loss of the cemento-basilar level, lots of changes histologically to vasculature, and lots of changes, cumulative changes to ultimately bone. This can lead in some cases to levels of dental caries, of course, but also as a direct effect, bone necrosis over a period of time. The mandible is typically more of a target in these patients as opposed to other areas of the head and neck. So we see lots of changes with these types of therapies. When it comes to oral defects, we see a number of patients that present to our clinic. Some of these are congenital. Some of them are acquired disease over a period of time. It could be benign pathology. It could be malignant pathology. Some of these are trauma-related as well. So there's a variety of principles, certainly, that we use in prosthodontics. Some of these patients can present with congenital malformations, such as this gentleman who had an isolated cleft palate and cleft lip, and this resulted in a delayed loss of his dentition over a period of time. Now, if we look at this, we know that there's probably some controversy. Some of our patients will be treated with dental implants as a result of this. The question is do we bridge this together or not? Is there some rule of thumb that we look for? I mean, if we look at patients such as a colleague of mine that showed me one of his patients like this, we see some mobility, inherent mobility. Even when there's a diagnostic trial arrangement, you can see a difference in mobility of these segments. So as a result of this, and using rigid connectors across these types of defects with this patient who had a cleft palate, isolated cleft palate, is it appropriate to connect it? Some of the skeletal anchorage that we've learned from our use in treating patients of this type, the use of craniofacial anchorage with extended length implants into the zygoma has been proposed, and it can be effective in a lot of these cases. But truthfully, many of these cases can present as a real challenge to us prosthodontically. Years ago, Brannemark came up with this technique specifically for patients that had oral defects, maxillofacial type defects that required some level of skeletal anchorage in order for a prosthesis to be made. So this, if we look at some of our traditional ways of handling patients that have an oral defect with an obturated device, these are our Armani classifications. We're looking at a number of tenets, 5 of these for routine prosthodontics, and a 6th one with indirect retention, more so for our patients that have a maxillofacial or a maxillary defect. We can see that our Armani class 1s and 4s rely on some method of indirect retention, and often it's very difficult to grant this based on the amount of surgical defect that's been evident after treatment like this. So this becomes a challenge in treating patients with particularly a defect that has occurred from resection of a tumor in the maxilla. And if we look at classification systems from this time, there's a number of them out there, approximately 6 of them out there. Only one of them, the Okai classification, by a colleague of mine, Devin Okai in New York, had come up with his colleagues in otolaryngology, Buckbinder, Erkin, and Gendon, and looked at this as a way of giving further classification specifically intended for prosthetic reconstruction. And a lot of this is looked at, if we see our classification, there are a number of really apportioned areas of the maxilla that will require some consideration. A 1A certainly are not a dental component or a dental alveolar component. The 1B may be a posterior lateral defect that we encounter fairly often. Class 2s are midline resection of approximately 50% or less of the palate. This can be bounded with or without canine or pillar support. And a class 3 that has more than 50% of the palate resected. There are subclassifications of F for orbital floor and Z, zygomatic process. So these are very interesting, particularly in the last years where we've begun to use more of these extended length implants. At the time, Dr. Okai and his colleagues had suggested soft tissue flaps, simple obturators for class 1, but the more extensive defects would include more of a comprehensive microvascular reconstruction. So we could look at this a number of ways, but I think a more updated version of this in 2018 had indicated a significant difference in the way that we approach these types of defects, and we'll get into that in just a moment. If we're looking at 1A defects, very much like the isolated cleft palate that we just looked at, we can usually use skeletal anchorage. Often in these patients, there's very little bone to obtain proper anchorage for prosthetics. And this patient is using a milled prosthesis supported by 4 extended length Zygoma implants. So these can be very helpful in these cases. Being a cleft palate, again, we have more skeletal anchorage and less movement with these types of bony segments. Occasionally, we can use a posterior lateral defect reconstructed with a combination of techniques. It could be also using extended length implant, a single dentoalveolar anchorage as well for a segmental type reconstruction. This was used in combination with a radial forearm flap, and even a temporalis flap can be used in these cases to close off the defect and provide both skeletal anchorage. So combination type approach to this type of defect. The other approach over the years would be to ward off mechanical complications. So generally, zygomatic implants are certainly contained within bone at the apical portion, but the coronal portion may not allow a rigid or an infinitely rigid construct. So we see here some level of prosthetic loosening with this device after approximately 3 years, and approaching this can be tricky. So replacement of these components periodically is preferred. Some of our patients will present with midline defects and associated fistula. This gentleman presented with an adenoid cystic carcinoma and over a period of 10 years lost the balance of his dentition due to radiotherapy compromise. So making a prosthesis for these types of defects can be anchored by skeletal anchorage using extended length implants. So the defect is still patent, but the purpose of the primary bar is to give us support and retention for an overlaying prosthesis, as shown here. Sometimes there is no defect. This patient presented with a lymphoma of the maxilla. This was resected, and the soft tissues were in combination with systemic chemotherapy maintained. So the patient did have some skeletal anchorage with adjoining osseointegrated conventional endosseous implants. So even though a portion of the maxilla remains, it is possible to keep this area as a separate oronasal demarcation. This gentleman had presented with a calcifying epithelial odontogenic tumor, and this was a combination. Since it was a fairly large resection, there was a fair amount of bone missing, so a microvascular graft was proposed to replace this missing portion of the maxilla. In combination, as a class 3, a greater proportion of his palate would be missing. So skeletal anchorage was also used in combination with endosseous implants into the flap. So a physical demarcation using microvascular flap along with skeletal anchorage was used for this type of Okai classification 3 defect. So in looking at these patients and the more contemporary ways of dealing with these defects, some of them have been updated again in 2018 by the same group, and the 1C classification was extended to include the anterior maxilla. You might be able to change this with something as simple as an obturator device, or you could certainly make a fasciocutaneous reconstruction using soft tissue, either local or distant. There are additional classifications of the subclass F and C. We won't really get into that. It doesn't pertain to intraoral rehabilitation. But this certainly is one way to approach complicated maxillofacial type defects. So there are some limitation in using Zygoma implants. We see that there's an advantage certainly with getting some skeletal anchorage, but these implants are not infinitely rigid. So placing ceramics on them, placing them to support an entire load, we have to be very careful in the way that we do that. There is some flexure, and if there is insufficient distances, we have to be really careful, as there is significant flexure with these types of implants. So reconstruction of the maxilla, as I mentioned, started with a number of approaches to it. Some of this was non-vascularized. As vascularized reconstructions became more commonplace in the 1970s, this was in the early 1990s. This was approached from our colleagues at Sloan Kettering, and reconstruction using radial bone and forearm. The amount of morbidity associated with a donor site kept this from being used commonly. So there are other sites that are used to reconstruct the maxilla, but this was the first approach, and it was successfully shown that this could close off these defects. This is useful especially for patients that present, such as this patient who underwent pretty much a total maxillectomy, including the orbital floor and zygoma. So this patient had been seen years prior, was unsuccessful in wearing an obturator prosthesis, had trismus, had migrated mandibular dentition, and approaching this case was complex. The amount of tissue needed was tried several times, ultimately resorting to donor site from the iliac crest via a deep circumflex iliac artery graft from this area, vascularized. This area was previously radiated, so the recipient bed was compromised in many ways. Ultimately, this patient was restored with having, number one, the defect closed off. Her facial support was good, and also subsequent implant placement into the remaining maxilla and DCIA flap. So this patient actually had a good result. The mandibular dentition was taken, and the occlusal plane was lowered just to facilitate interarch distance reconstruction. Some of our patients present with traumatic types of wounds. Unfortunately, this patient had sustained a total necrosis of her maxilla secondary to an elective maxillary osteotomy for orthognathic surgery. This was referred to us from an outside institution. Patient had undergone multiple attempts at reconstruction with supportive hyperbaric oxygen therapy, as well as additional types of antibiotics. All were unsuccessful, and the patient resulted in presentation with our clinic and our reconstruction team, requiring a total maxillary reconstruction. So it was approached from more of a planning technique, whereby vascularized fibula graft was going to be used. Since this was not truthfully malignant disease or neoplastic disease, we were able to provide mostly just bony construct and some soft tissue to close this defect as a result. So at the time of resective surgery, the patient was planned previously as a 3D printed model and a construct using vascularized fibula to this area. This was reconstructed. The patient underwent a period of time where the graft was consolidated, and ultimately implants were placed in it in the second stage, and fabrication of a metal ceramic prosthesis for this patient. She continues to do well, but a significant defect, of course, resultant and restored with vascularized tissue as well as a bone-anchored prosthesis. So these cases can be quite extensive. Some of our patients do indeed have secondary effects from their therapy. This patient underwent treatment with chemotherapy for premyelodysplastic syndrome. She had experienced, unfortunately, a mucormycosis This is a fungal disease affecting the maxillary sinuses, and frequently maxillectomy, surgical resection, is required along with antifungal therapy. So this patient underwent a large resection of the anterior portion of her maxilla. You can see her facial collapse, and she was fitted with a prosthesis beforehand, but did not function well with it, mainly due to its lack of stability. So the use of a scapular graft was contemplated for this patient. Some 3D model reconstruction approach was used for this patient, and she ended up doing quite well after the reconstruction. The amount of reconstruction, certainly with a viable flap, was favorable. However, it was seen over time that the posterior portion of the left side was not unionized. So we decided to use the native maxilla as support for a fixation device. So we treated her with a full arch metal ceramic prosthesis, allowing more stability in these areas. So the left parasagittal site ultimately had calloused, and the patient continues to do well, some 5 years out of therapy now. Good separation of her oronasal defect, good facial support, and essentially normal functioning. The advent of microvascular surgery had begun with a lot of work with conventional prosthetics, but looking at mandibular continuity probably was the stimulus for a lot of the maxillofacial reconstruction we see today. This was approached again from our colleagues at Sloan Kettering in New York. David Hidalgo was one of the first plastic surgeons to use the technique to restore mandibular continuity, and his group there still continues to this day in restoring these patients. This is a very innovative approach to restoring mandibular continuity. It's a bit different focus than maxillary reconstruction, honestly. These are often linear defects, and reconstruction can still be somewhat involved, but the amount of soft tissue in these cases can be looked at in a number of different ways. There is a spatial problem with reconstructing these patients. Number one problem that we see with it is often we're asking the fibula to do a different job than native mandible does. We have two components of native mandible, basal and alveolar bone, and the fibula is often asked to do both. So the housing that we have in the native mandible is very different and often dislocated in reconstruction attempts by using vascularized fibula. This is more evident in the posterior and sometimes the anterior as well. So the occlusal plane and the position of the occlusal table is often very different. Keep in mind, these patients are anesthetic. They don't necessarily have a sensate feeling with this type of microvascular reconstruction. So use of cross-bite or altered occlusal plane is a bit different. Excuse me. So these patients can do often very well. Some of them will present with a need for angulation correction. Sort of a bayonet-shaped prosthesis can be looked at in these patients. So the occlusal plane and where it's proposed and the direct line of sight over the implant can be very different in reconstruction of these patients. Keep in mind, the external contour of the fibula is important as well, and we want to have facial support in comparison to where the original position of the occlusal table is. So we have to keep that in mind. You know, some of these cases were going back years ago and looking at a two-dimensional template for reconstructing mandibles. If you think about it, this is a three-dimensional defect, and this is taken from an otolaryngology textbook, giving the surgeons a guide that essentially is a two-dimensional template. So maybe this is not as sophisticated as we would like, but indeed, this is quite complex. There's a number of algorithms that have been stated over the years. This is one from a Swiss surgeon by the name of Dennis Rohner. Dr. Rohner had proposed an occlusal-based reconstruction using templates. This is just showing a maxilla that's reconstructed with vascularized fibula, and the use of a provisional prosthesis to guide that reconstruction. It was the first real approach at that technique, and there have been many, many different levels of it as a change since then. Our colleagues in Alberta, Canada, from John Wolfart and his group at RSM, had looked at anatomical reconstruction, which truthfully, up until this time in the early 90s, was the only way to really approach this. In other words, the intuitive reconstruction was live time. Surgeons would look at things and kind of get a general idea of where it should be and reconstruct to that level. Since then, we had some digital tools that allow us to do that, but not necessarily guided per se. And then we have another development in the secondary phases that allow us a planned and guided reconstruction. And even further yet, the occlusal-based reconstruction is something that we like to use in this day and age, so we can possibly orient the bony base and support the occlusal table well. Live time navigation and robotics are used, certainly in our neurosurgical teams and some oral reconstructive teams, but we haven't really driven yet to do that, but I suspect we will in the years to come. All of these elements are surgical design and simulation coined by Dr. Wolfart some years ago. But there are these 5 levels that we see in various capacity, and it's our goal to provide an occlusal-based type reconstruction for these cases. So some of the virtual planning that we do, can be very simple. For instance, this young woman who presented with an osteoblastoma. This is a benign pathology, although odontogenic, and it's treated pretty similarly with regard to resection. This was planned in advance with virtual surgical planning, which is certainly trademarked by a company here in the States. This was planned to be reconstructed using a microvascular fibula reconstruction. There are some elements of it that allow this occlusal-based reconstruction to work well. You can see the occlusal table is very close where the accesses of the implants are located. So this has been shown to be helpful, and the Alberta group definitely looks at this as their outcomes are measured. They probably lead North America in this reconstructive effort. So we look for great work to continue to come out of their institution. So even just a 6-year follow-up, you can see this patient treated with a metal ceramic prosthesis has done well. Her facial profile is fairly symmetric and aesthetic. Her cervical scarring is minimal, and she has done very well with this reconstruction. Classification of mandibular defects has been proposed by a number of people. Brown is probably the more contemporary classification in Lancet Oncology 2016. And there are a number of standard measurements that are made with most mandibles that we can look at. And we see that there are various classifications, the canine and the angle of the mandible being pillars of class 1s, 2s, and 3s. Class 4 is also a possibility where the angle from both sides is removed and no pillars exist for reconstructive efforts. So there is a subclassification C that includes the condyles for class 2, 3, and 4. Some of these cases do involve consideration. This young man had presented to us as a presentation from abroad. He was from Saudi Arabia and had presented with this large osteosarcoma of the mandible. Had difficulty getting and acquiring treatment in his home country. So he presented to our clinic and was staged, the first off in eliminating the tumor prior to his adjuvant therapy with chemotherapy. And you can see this is certainly a class 4 subclassification C with resection of the tumor and a portion of his mandible being left on his right side. You can see that in the primary photograph. He was reconstructed with 2 vascularized flaps, one from the radial forearm, the other taken from the fibula. And reconstruction of his mandible was undertaken secondarily with osseointegrated fixtures and allowing a bone-anchored support for his remaining opposing dentition. So this patient had done very well, remains disease-free. His disease was isolated monostotically to just his mandible. Some of our cases are a bit more involved as well. This is a similar type case presenting with benign pathology. This was progressive osteomyelitis of the mandible. This patient was treated over many years, approximately 8 years, with intravenous antibiotics and curettage. The cause was idiopathic. There really wasn't a good reason for it, and unfortunately the patient had lost her mandibular dentition as a result of trying to maintain this through periodontal curettage over time. So it was offered at one point for mandibular reconstruction. The patient ultimately had agreed to this. This was accomplished with a planning technique that involved a 3-segment type fibular reconstruction. And this attained the patient's desire to have this done and leave with some level of facial support and dentition. So there are some advantages in using models in these cases. We can certainly assimilate at the time. Some of the platforms we had were limited with regard to immediate reconstruction. So we used the conventional technique whereby an occlusal device was made at the time of surgery. We would load this and use this as a stabilization device as well. This is not unlike using external pin fixation for comminuted fractures. So this is what was undertaken with this patient. The day of resection, you can see the specimen to the right, which is quite moth-eaten and unfortunately not viable. The ascending rami were to some degree affected, and you can see that as well. The microvascular reconstruction was accompanied by a 3-dimensional plate that was custom built and milled. Implants were placed and ultimately affixed at the time of surgery. The patient was on a non-chew diet, but the mandible segments were affixed in reduced in a fashion from both the hardware as well as the implants. So certainly some advantage. Subsequently, the patient was restored using a metal ceramic prosthesis single piece. This is published in the Journal of Oral and Maxillofacial Surgery, 2017. So comparing our surgical design and simulation to intuitive reconstruction, we began to take some notice. I mean, how much time does this really save us in comparison? Approximately 1 hour. And our cost for the operating room were at least $180 per minute. So this equates to a fair amount of financial outlay. And if we can save an hour of operating room time, it's certainly worth it with the use of these devices. So how about long term? How about the time taken to a definitive reconstruction? We see that there is, even though the numbers that we've compared to are somewhat different, a simultaneous occlusal-based reconstruction does save us a little over 120, 160 days. So this makes us excited about the future with this type of therapy. And for those in the long run, does it make a significant difference with intuitive design? It certainly can, and you can see this factor as well in comparison. So the complications we see in these patients, both maxilla and mandible, we see a number of these cases where soft tissue hypertrophy has eclipsed all other problems. Sure, we have other problems with scar contracture, especially when there's radiotherapy that's encountered with these patients. But soft tissue hypertrophy remains one of probably the biggest one. The materials that we're using in these cases often are porcelain fused to metal. There are advantages in using PFM restorations. However, resin to metal is the second most common one used in our practice for a variety of reasons. If we look at the follow-up time and the number of prostheses we have, you can see the greater proportion of them were in the first year of follow-up. And the complications, again, that we see are eclipsed by soft tissue leading the way with evidence in the first year. There are a number of these cases that continue to do well without any complications, but the incidence of even higher than 40% of these cases would seem likely. 20% are what were intervened with, but the incidence we feel is much higher than 20%. So why does this happen? I mean, it happens for a number of reasons, right? It can happen from different types of tissue that's been transported to the head and neck region from dermis. This can be secondary scar formation. It can be a change of microbia. What we've found helpful is to use a surgical stent at the time of either placement and or recovery, uncovery rather. And this makes a big difference with regard to this type of approach. So the etiology, we've begun to look at this, and it could be a varying degree. Some of this is the body's attempt at walling off some level of friction, perhaps. Keep in mind, these patients have had all their anatomy rearranged and modified in such a way where there's an increased amount of friction, both from the tongue and the cheek, what remains. It may be mobile tissue. There can be a bone positioning outside the confines of the oral cavity, frequently is what we see with these patients that have been reconstructed. The microbial load that these patients experience, particularly the ones that are radiated, also seem to have a different level of bacteria. And there may be some patient-specific aspects of this with regard to their access to clean the prosthesis. So this makes a big difference with these patients. We're really not sure why this happens, but we've noticed it in many of our patients. What we've also seen with these patients is significant scar contracture. You can see this patient originally treated for an ameloblastic carcinoma in 2012, and over a period of 6+ years, she's imagined to have tethering of her lower lip, progressive exposure. She went through 2 revisions of the prosthesis during this time and ultimately underwent a further reconstruction, negating even the use of the prosthesis. So scar contracture with these patients can be progressive. This patient very similarly was treated with mandibular reconstruction, ultimately maxillary reconstruction as well, for spontaneous occurrence of squamous cell carcinoma. Some patients will manifest this even just in a short while. This is just a few years with this patient, but progressive scarring in these patients often will prevent us from choosing a metal ceramic design, mainly because we can't really recontour this type of prosthesis very well. So the use of resin to metal restorations in these patients makes really the most sense. It allows us to modify the prosthesis easier. So again, of course, we have a plethora of choices for these types of patients, but suffice it to say there's a number of materials that we can use, resin and metal as I mentioned, but these seem to be the most advantageous. If we look at the way that we're manufacturing devices, both placement devices and treatment devices, this is typically in a medical facility the way that custom hardware is manufactured. We're used to this. We have a number of our patients that undergo placement based on a surgical device. We allow our technicians to create a surgical device, don't manufacture it. But I think we need to be looking at this in a different way. A number of these patients will require advanced pre-processing of some sort of data set. And often with maxillofacial prosthetics, there are multiple data sets that have to be imported. It could be certainly radiologic, surface tissue, as well as dental information. So the use of manufacturing from a technician and secondarily a simulationist, someone who's familiar with arranging these data sets, is needed. And a lot of our approach to recreating this environment has been delegated, at least by our medical colleagues, from a simulation design specialist. And certainly our radiologists have helped us with that. But these are 2 different pathways. We have really a lot of help from our technicians, and we feel that the approach taken with a simulation specialist is something that if we're going to do this type of work, we feel it's a different workflow and it probably works out a bit easier to have this design. Some of our colleagues at Canada, again, have done this very well. They have a Master of Science in Rehabilitation. These are 1 to 2+ year programs that allow some familiarity in looking at data and processing it a certain way. So simulation specialists do have some semblance of formal education, and we're looking forward to implementing this type of education in our own facility. So what's for the future of maxillofacial prosthetics? We see a number of our patients that benefit from maxillofacial reconstruction. Some of this is microvascular surgery, as you've seen. Some of this is using human tissue allograft donation. This one of the first head and neck reconstructions was done with a donor using vascularized tissue from a deceased donor. And at this time, in 2005, this was the first done with the Amiens group in France that had looked at a degloving defect of a patient. I think she was bitten by a dog. And this reconstructed her lower 2/3 of her midface, including the soft tissue of the nose and the lip. This has changed quite a lot since this time, and it's gone for many other levels of reconstruction. In our facility, we had a young man who sustained a ballistic injury to his midface, luxating his mandible and maxilla and nose was done with autogenous vascularized bone reconstruction. And despite all of this effort, he still had difficulty in integrating into society. He was ridiculed. He works in the Midwest and has had an isolated experience, even with reconstruction of a prosthetic nose. It was very difficult for him to fit in, as he described. He came to us in 2007 with this injury and really was never happy with the final result. Even though he could walk and talk like you and I, had a very difficult time fitting in to society. So he was considered for facial allotransplantation of the lower 2/3 of his face, including a Lefort 2 operation and mandible angle-to-angle operation. At this time, you can see the side projection of his face lacking, very difficult for him to, even with prosthetics, to fit in, as you can see. Some of the work done with our plastic surgery group had isolated and found a donor. Here, the donor operation was used in a 52-hour operation whereby it wasn't just an anatomical type reconstruction or transplantation of the face, but also a neural type mapping was done of the facial nerve to provide the patient with some semblance of anatomical and facial animation as well. So this is the organ here prior to its transplantation, the recipient, of course, being prepared and actually mapped out in the same way, where his facial nerve branch was contacted with an electrode, looking at this from a stimulatory level of reconstruction. So this patient had been considered for reconstruction, found with a donor, and fitted with a surgical placement device. These were surgical stents that allowed resection of the existing bone as a Lefort 2 operation, as well as getting an idea of the projection of the teeth in the donor organ so that enough soft tissue could be maintained in the recipient's face to wrap around this transplantation. So this is the organ affixed in place after 52 hours of surgery. This was used in teams with our plastic surgical group. Samir Mardini was the main surgeon orchestrating this. Sometime later, the patient was evaluated, both pre and post. You can see the projection of the skull with 3D reformatted CT, and you can see what a difference just the facial projection made. At the time the patient was diagnosed, the donor, I should say, was diagnosed with malocclusion, periodontal disease, and dental caries. All three of these factors were treated over a period of several years. So the patient underwent caries removal by my team. The periodontal team had resulted with their therapy, and orthodontic therapy was done with cosmetic aligners just to cut down the amount of inflammation intraorally, leading to possible rejection. So the patient has some 4+ years later. This was done in October, I believe, of 16. We're approaching his 5th year status post reconstruction. And you can see there's a little bit of facial asymmetry, but it's a pleasing asymmetry. The patient has done very well with his reconstruction. And functionally, you can hear him as well.
I'm at Mayo Clinic. I'm at Mayo Clinic.
Happy birthday.
Happy birthday. Happy birthday. Happy birthday.
So this certainly is one of the salient features of facial transplant you'll see. I think the patient has done very well with this. So in a nutshell, surgical design and simulation is very helpful. It helps in increase the predictability, the treatment time, and our spatial result as well. For complex care, fibular reconstruction, it can be quite versatile for both the maxilla and mandible. The infrastructure used to accomplish this based on the institution, it may be beneficial to have a vendor supply support for these cases. Having this in one roof is a challenge, and quality control can also be a challenge with these cases. But I think so many things have changed in the last several years. We're able to offer patients much more than we had been prior. So I appreciate your attention today, and I'll be glad to entertain any level of questioning.
All right. Thank you so much, Dr. Salinas. I do have Dr. Srivastava here, who will be coordinating the.
Hi, Dr. Salinas.
Hi, Dr. Srivastava.
Thank you. Very good. Thank you so much for the really, really great presentation. And that's most of the comments that you're receiving right now as to how amazing that was. And there's so much information that you presented in such a amazingly concise yet detailed way. So thank you for sharing that with us today. There are several participants here in the audience who are dental students in their early stages of career. So there are some basic questions really related to microvascular free flap. If you could explain that a little bit more to them, as well as do you face any situations where you're not able to do a free flap reconstruction?
Very good question. Yeah, that's a common question. You know, just to keep it simple, the consideration for microvascular reconstruction is part and parcel to, can we restore these patients with conventional prostheses? Now, in the mandible, I think that creates the larger the defect becomes, the more critical it becomes to restore a patient with a conventional prosthesis. So in some of these cases, we look for donor tissue. It may be bone, it may be just soft tissue. But if we're restoring mandibular continuity, we would want to consider a linear type bone, like the fibula. So in some of these patients, they may be good candidates. Often what is done is an arteriogram is performed of the lower limb, assuming there's no arterial blockages. There basically are two techniques to doing this. One is an arteriogram, and the second is looking for overall coagulability. In other words, if the patient has a tendency to clot, they may be placed on blood thinners prior to this time. But the big picture is, can this tissue be transplanted without worry of having a clot form in either the artery or the vein that's being used to anastomose it to vessels in the neck? Often it's the facial artery and external jugular that this is anastomosed to. So these are primary elements if patients can actually undergo this type of operation without risk of a clot forming in the vasculature. It's the vasculature that keeps this bone viable, and it allows the bone to be present for the longest period of time. Without that, we really resort to failure or premature loss of the flap. And this does happen in our population, despite the fact that these patients are fitted with an arteriogram beforehand. We want to make sure they're the proper candidates for it. That's sort of a broad answer to the question. I trust that was sufficient.
Thank you. That was great. So before fibular free flaps became so mainstream, there was a lot of iliac crest and costochondral grafts rather than flaps that were done. Do you still see any use of that in your clinical practice?
Yeah, we're seeing less of it. I think transferring osseous tissue often is at the mercy of having a proper blood supply. Without that, many of these grafts, I mean, we've seen that with costochondral grafts, we've seen it with free iliac crest grafts, we've seen it with iliac marrow, but all of these bone grafts, if they're not contained within a wall of native bone, they frequently will resorb away. Some of this is just the fact that there's not sufficient blood supply to maintain them. So honestly, there's so much microvascular reconstruction being done, we're seeing less of free non-vascularized grafts that are being used.
Sure. There was one more question, and that's related to just overall complications related to radiotherapy when we're talking about reconstruction, free flap reconstruction, as well as implant rehabilitation. And how frequently do you experience, complications, not necessarily just failures?
I assume they're meaning implants. So with implants, there's a variety of feeling about that. The question is it beneficial to place the implants prior to an osseous flap being radiated? Often the time taken from convalescence of the reconstruction to the very start of radiotherapy, when the dose is considered lethal for osteoblasts, that time taken typically is the time that it would take an implant to become integrated. So there's not a lot of data. There's only one study I'm aware of by Buckbinder that looks at that. Is there a difference? I would suspect that there is. The question is this long term? Albrechtsen and Kranovic had looked at this as well. There's a number of studies that are beginning to look more at this. Are we seeing a different level of survival with implants and radiated bone? Absolutely. There's definitely a difference. The question is, does it make a difference if the implant is integrated before the radiotherapy takes place? And again, this is a dynamic tissue. It turns over all the time, especially when there are loads placed upon it. So I suspect we'll continue to see a level of loss, 60th percentile loss at approximately 10 years with these types of implant supporting tissues. Right.
And do you see any particular difference with zygomatic implants and maxillary reconstruction when radiation is part of the plan?
That's an excellent question. And my colleagues and I look at this frequently. So one of the most sensitive areas of the head and neck to avoid with radiotherapy is any neural tissue, which includes the orbit. So as a result of that, we'll find that many of these, the apical portion of the zygoma implant is in bone that's been irradiated in less than 45 gray. And if that's the case, frequently, even with radiotherapy, these patients will still continue to maintain osseointegration with zygomatic implants. So that's one of the reasons why we're considering more the use of remote anchorage with zygoma implants than we are with conventional endosseous in these types of cases. Good question.
Great. Thank you. That's all the questions I had from my end and from the attendees here. So thank you very much once again, Dr. Salinas. I'll give it back to Dr. Onoriobe.
Thank you so much. There's one more question here. He said, how do you contour bone tissue to get a good aesthetic outcome? I don't know if that's related to what you...
I'm assuming that they're talking about the aesthetics of this. If that's the case, you know, it's really good to have an occlusal-based reconstruction. If that's the case, looking at soft tissue drape over this, if it's anterior, truthfully, does become a challenge. And I think reconstruction of the maxillary anterior area is the most critical one. Occasionally, there'll be a revision surgery required if this is not optimally placed. The unpredictability of this, we have some predictability of looking at the way bone heals, right? We know what that's going to be. That's pretty static. What we don't know is the soft tissue that accompanies it. Mm-hmm. And if that's not planned for in additional volume, often it can lead to the need to either reposition the bone or possibly to modify the soft tissue. So this is something I think that we're all still learning, especially with microvascular grafting. So that's about as best of an answer I could give.
Okay. Thank you.
Thank you.
One last question here. This is Patrick. Patrick is a surgeon from Uganda. He says he had a patient with a class 3 mandibular defect and a transvestibular plate was inserted. He said, how prosthesis for such a patient made?
Assuming that the transmandibular plate was the prosthesis support itself, those can be very beneficial. If I understand the question, it's like how do we image that ahead of time?
Mm-hmm.
And some of the more advanced work done with our vendors will indicate that a transmucosal portion of this hardware can actually be prosthetic support, and that is very exciting work. The concerns we have are, if these wounds are benign type pathology, then that's one approach. If they are malignant, where adjuvant therapy is needed with radiotherapy, I think I'd have some concern for that because of the progressive scar contracture we talked about. But I do think that that's becoming a very exciting approach, minus the need for microvascular surgery. The hardware itself, assuming it's still enveloped in soft tissue and it doesn't dehiss, assuming it maintains that relationship, that's a very exciting approach I hadn't covered today, but I really do thank them for the question.
All right. Thank you. Thank you so much. I don't know how you did it. I don't know.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator